as one of the published papers published by us in 2015, which is around 10, 15 years ago, where we showed that the infertility or prevalence of infertility in Saudi Arabia, i.e. mainly in the Eastern province, is about 19.7%. Yet we have to remember that we have a lot of consanguinity, so we have a lot of genetic issues where we are working in the reproductive for other reasons rather than the infertility. And still, we're having a lot of challenges. It's not only to achieve a pregnancy. We do have a lot of other challenges, yet we have a lot of problems and areas not yet explored or completely known, i.e. when we are speaking about recurrent miscarriage, when we are speaking about recurrent failures, a lot of things on genetics still needs to be explored. All of these factors, patients who are suffering from recurrent implantation failures. And I guess this is not only a problem to our patients, it is something for the physicians where it's a failure for the whole system, for the whole center. You want to achieve a better pregnancy rate, a better outcome for all the patients. And here we go. Science is dynamic. If we don't go with more technology, with more research, definitely will not approach what we are hoping for. So tonight, hopefully, we will highlight, we will look together, we will discuss some of those areas, maybe which need to be looked at. Because if we will look on the recommendations, we are speaking about issue recommendations, yet we are having a lot of deficiencies, a lot of work is going on. But if the patients are going on, they will have a lot of things to look at. Everyone is telling them, you have to go this way, that way. Yeah, we understand that there is no black and white in our field, but at least we may put some good traffic lights for some of the procedure or maneuvers where we are doing. So I would like to welcome you all again. Dr. Mariam will be our first speaker. So Dr. Jibri will present. Thank you very much.
Thank you. Thank you. Thank you, Professor Haifa. Our speaker now is Dr. Mariam Dashti. Dr. Mariam will tell us about the immunology of infertility and practical aspects. Please, Dr. Mariam is a professor in the Arabian Gulf University, and she had been working and a leader in Bahrain in the assisted reproduction. She is the first, actually, to start working in the IVF labs with Dr. Nabil Rizqallah, God bless his soul. And they started the work of assisted reproduction long time ago, more than 35 years maybe ago. She had been all the time very supportive to all units in Bahrain in the aspect of assisted reproduction. And she is also the leader in the assisted reproduction. She is the head of Bahrain Fertility Group, and she will talk to us today about immunology. Please, Doctora. There is no mic there.
Thank you. Bismillah ar-Rahman ar-Rahim. First, I would like to thank EXPRESSMED, ONCOHELIX, the organizers, Dr. Kadhim, Dr. Muhammad, and of course, my dear friend, Professor Salam, to moderate this session. And I would like to say hello to all the audience. شرفتونا اليوم. دكتورة هيفا أهلا وسهلا فيك. It is amazing that how tonight brings immunology to assisted reproduction or to reproduction. My PhD was in clinical immunology, and I worked with Dr. Iman in Arabian Gulf University for 30 years. I taught students of medicine, immunology, basic science, But on the other side, I work in the IVF, and we established the first IVF center in Bahrain in 1988. And since then, we did a lot of work in immunology, by the way. We did publications, we had poster presentation. And tonight, really, it's very important for me to present the sum up of what I did in the last 35 years. Today, I will be talking about immunology of infertility. Basically, the problems of immune system in reproduction. And I really feel very sad and very stressed when I talk about this issue, especially female infertility, when it comes to autoimmune reactivity, because it's not easy at all. Really, it's not easy. I have witnessed several gynecologists working in vicinity with patients, and it is very sad that the patient gets pregnant and in the beginning of the pregnancy or later miscarries. And there is no reason for that except that she is having something wrong inside. And today we're going to talk about autoimmunity, the condition. It is a condition where immune system fails to discriminate between self and non-self. The structural or functional damage is produced by action of either immunologically competent cells or antibodies against the normal components of the body. For each 1,000 person, there is 5 to 6 of adults affected, where 2/3 of them are female. Today, the 40% of human diseases collectively are autoimmune in origin. And it is very frightening. I think in 1980, when I started my PhD, there were only 20 or 30 max autoimmune disease. Today, we are facing horrible list of autoimmune diseases, which is affecting from the child to the adult. For the disease to become autoimmune, it requires immune reaction is directed specifically to self-antigens or tissues, and the reaction is of primary pathogenic significance and not due to tissue damage. So the autoreactivity happens, then followed by tissue damage. Also, when you investigate the patient, there is no other cause. So that's why you incriminate autoreactivity into the etiopathogenesis of the disease. You can see the list of autoimmune disorders. This is actually, it's a very moderate, but the list is very big. We couldn't put it on the screen. If you can see, the first one is infertility. See, infertility is not an autoimmune disease. It is a consequence of autoimmune reaction. And there are common symptoms which are present in all these disorders, or some of them, and infertility is one of them. Infertility can be caused by different causes in female, like blockage of fallopian tube, like endometriosis, polycystic ovaries, abnormality in hormonal imbalance, and so on. In male, there is one particular condition leading to impaired sperm. Impaired sperm, quantitative and qualitative. And sometimes you find antibodies against the sperm in human semen. For normal immune response, you require endogenous factors such as normal immune system, anatomical and histological. You need normal ontogeny of T cells, that is the development of T cells. T cells are very important, not only for T cells themselves, but also for B cells. Normal production of cytokines, where they are produced, how they are produced, the target cells, and the resultant reaction of the cytokine with other cells. Then also very important is functional suppressive mechanisms against autoimmune flare-up. This process is called self-tolerance. And self-tolerance is very, very important for pregnancy because the body must tolerate the immune reactivity against fetal antigens, especially in the beginning of pregnancy. Must tolerate the antigens coming from the husband, which appears in the embryo. This happens in an organ called thymus. Of course, everybody knows thymus. Thymus is the place for ontogeny and for maturation of the T cells. It happens through the whole life of human being, but it starts with week 5 to 6 of gestation. The thymus analog forms from the third pharyngeal pouch, and in week 8 to 9, T cell progenitor or thymocytes colonize the thymic rudiment and differentiate into cortex and medulla, the thymus itself. In week 13 to 18, thymic processing happens to produce normal competent T cells through two processes called positive and negative selection. This is the thymus. When the thymocytes are produced in the bone marrow, they enter the They enter the thymic cortex, and they get exposed to antigen-presenting cells called endothelial cells, called epithelial cells, and they have major histocompatibility complex molecules on the surface. Once they encounter thymocytes, the ones which we bind strongly to thymocytes, they pass. That's why we call it positive. Then they pass from cortex to medulla, and here there is an interaction with the autoantigens. So autoantigens, the cells which react with autoantigen on dendritic cells, they have to die. They go through apoptosis. Whatever is left is normal T cells coming out and go to the bloodstream. This is called central tolerance. Then they go to the peripheral tolerance, where reactive T cells act to fight against viral and bacterial antigen. Anything self-reactive which run away from this process, they are eliminated by other mechanisms, which you see it here in this figure. Immunological infertility is divided into two. One is male immunological infertility, and the result, it can happen due to infection or to injury. And the result is production of autoantibodies about sperm. And in the female, infertility is more complex, as usual, because women's reproductive system is far more complex than male, and the autoimmunity can occur in every single part of the reproductive organ, especially in the endometrium, causing implantation failure, fetal loss, recurrent pregnancy loss, and so on. The features found in the female infertility, when it comes to autoimmunity, it is antibodies against husband's sperm, autoantibodies against self-antigens, immune reactive cells against fetal alloantigens, and the effect is directed towards gamete development, blastocyst trophoblast formation, implantation failure, fetal development, and survival is very, very much affected. This is, everybody is familiar with this photo. This is just a simple, normal semen where you have beautiful sperm. And once you select them, you get beautiful sperm that you can use it either in IVF or you can use it in ICSI. Sometimes we find a photo or a phenomenon like this where sperm are clumped together. These sperm is clumped because of presence of autoreactivity with antibody, but not necessarily, because this can happen also due to the presence of some plasma proteins and it is called spontaneous agglutination. The problem with antibody is very, very difficult before the era of XC. Here you see the sperm, antibodies are coating everywhere in the sperm, but the problem arises when the antibodies are coating the head because it prevents binding of the sperm to the cell membrane in the oocyte, and it fails the fertilization. This is a survey which I did long time ago, and it was before era of XC and after intervention of XC. We had 1,108 patients, and they show we did semen analysis for them. Out of 1,108, we had 408 patients showing agglutination. And out of 4,008, we found 66 of them showing mixed agglutinin reaction, positive reaction. And in those days, nobody was doing this except myself because I had immunological background. Then from that, I used tray agglutination test to measure the titer of antibody in the plasma and in the serum. And we got only 38. That came down to 3.4%. These patients were tested with traditional IVF from 90 to 96. And the fertilization and implantation rate were not more than 10%. Actually, it was much less than that. It was 0 to 10. Only these patients, not the patients who don't have antibody. These patients, I used some of them. I sent them to Ian Kraft in Dubai to do XC because they started doing XC before us. We bought the XC machine in 1994, but we did not assemble it until 95. In 96, we started using XC for patients who are, for everybody, not everybody. I still prefer doing traditional IVF, but we did it for cases where IVF may not give good result. And imagine, in those days, we had implantation rate of mean 83% and, fertilization rate of 83% and implantation rate of 23%. Today, we are talking about implantation rate, تقريبا, would say 40 to 50%. Yeah, something 40 to 50. It varies from one center to the other, but in general, it is about 40 to 50%. Internationally, is the same, isn't it?
Yeah.
Yeah. Okay.
1 more minute.
Yes.
1 more minute.
1 more minute. Give me 5, Doctor, please.
5. I'll give you 5.
Talk about it.
I'll give you 5.
So the lesson is learned that sperm autoantibody hinders binding of spermatozoa to oocyte, and XC is the right technique to overcome this problem. انت كريم وانا استاهل ها دكتور. إيه. خلاص, let us bypass some of these slides, but this is a nice slide that subhanallah, pregnancy has immunological clock, and it goes through early phase, mid phase, and late phase. In early phase, you can see that there is a dampening of all the immune reactions to let this lovely embryo to implant and grow. In the mid to late phase, the body of the person heightens the immune reaction to fight viruses and bacteria. In the late phase, the body goes back to normal and establishes good tolerance against fetal antigens. Okay, the causes of recurrent pregnancy loss is versatile. Autoimmunity is one of them, but basically you see 40% of cases due to fetal aneuploidy, and then we have 25% of unexplained infertility, and then you have 10, 5, 6% of other causes. The antibodies reported in recurrent pregnancy loss include antithyroid, antiphospholipid, anti-gliadin. That is, I think, this against wheat gluten. Then you have antinuclear and other antibodies against endometrium, ovaries, spermatozoa, phospholipids, in natural and assisted conception. The methods used to detect autoantibodies include immunobead binding test, tray agglutination test, ELISA. All three, I have practiced them. There are methods also to detect immune reactive cells, far more difficult, and it requires a special instrumentation like immunofluorescence, immunohistochemistry, flow cytometry, and lymphocyte proliferation assay. The treatment include, all gynecologists I'm sure know about this treatment, include low-dose corticosteroids, giving aspirin, heparin, using particular in those with positive anti-nuclear antibody, use of hydroxychloroquine, in some cases hormonal correction, lifestyle intervention, and sometimes other modalities like immunized female with paternal leukocyte, infused female with IV, IG, and Chinese like some herbal treatments. In summary, so anti-sperm antibodies can develop in both man and woman. In the female, these antibodies cause sperm to clump, slowing down spermatozoa or induce loss in ability to penetrate the egg. Elevated natural killer cells are horrible, but they are essential for destroying infected cells. Yet, natural killer cells in the uterus, they may cause trouble with developing embryo. There is antiphospholipid antibodies can attack cell membrane, causing blood clotting issues in the placenta. Autoimmune conditions such as systemic diseases, SLE, Hashimoto's, celiac disease, can disrupt the hormone and immune balance required to maintain a healthy pregnancy. We talked about a sperm autoantibody in male and female, and in cases some prefer natural conception. The males are given steroid to modulate the immune reactivity. It works in very few patients with artificial insemination. Also, reactive immune cells is very sensitive issue and require a very careful therapeutic strategy to achieve healthy full-term pregnancy. In addition to serology and cellular techniques, molecular assays with high reproducibility, reliability, and specificity may be employed in investigating immunogenetic causes of infertility. And I hope our colleagues who are going to give a lecture later or presentation tackle this problem, because I would like to know more about this. Thank you very much for your attention.
Thank you.
And if there is any question, maybe later we can.
Let's keep the questions till the end,
later.
and we'll open the floor at that time for all questions.
Okay.
Thank you, Dr. Ahmed.
Shukran.
That was a very nice, quick reminding of the immunology of infertility. Our next speaker is Professor Bonam Dahramani. She is a clinical professor in Cunningham Medical School at University of Calgary, Alberta, Canada. Professor Dahramani is going to talk to us tonight about the missing piece of recurrent pregnancy loss, flow cytometry-based immune profiling. Please.
Thank you, Dr. Salam. Good evening, everyone. Before I actually start my own presentation, thank you so much, Dr. Mariam. You have made my talk very easy. Trust me, when I looked at this topic, I was like, oh man, this is a very controversial topic. But you actually have given us so much of background. I'm pretty confident that it's gonna make my talk way easier. And actually, you have supported with your own experience of many, many, many years. You have supported many points, which I'm going to bring in my talk. So thank you for doing this. I'm going to talk about the most important piece, which is missing in the recurrent pregnancy loss. I'll talk about some of the updates on the diagnostics part, because what I feel that there is quite a bit of knowledge about this pregnancy loss, IVF failures, but there is not enough evidences or not enough diagnostics available, or even if they're available, there is no awareness of being that available. So I'm going to talk about a little bit about that, and sorry, I'll use that. So I'll be covering a little bit about the maternal immune tolerance in implantation and pregnancy. We'll review some of the flow cytometric-based available tests and their principle, and we'll interpret some of the immunology-based tests, and we'll discuss current evidences which are there in literature. And at the end, I'll close my topic with discussion on the clinical utility and the limitations. You all are an expert. I should not be even discussing this, but just, to start my talk, it's nice to know what is recurrent pregnancy loss. So of course, it's a multifactorial clinical challenge. And most of the international societies currently define that if you have more than two or more than two consecutive pregnancy loss in less than 20 weeks of gestation, that's defined as RPL. So I'll use the word RPL from now because, of course, recurrent pregnancy loss is a little bit big, and it affects at least 1 to 2% of reproductive age women, and it is responsible for over 15 to 20% of all recognized pregnancy. There is a big effect of this pregnancy loss. Not only will not touch the financial impact, but there is definitely a big impact on the emotional and the psychology of the person who is going through this. And that there are many cases which are still, there is no answer why this happened. So we'll try to find out some of the venues from which we can at least try to answer few of them. And as Dr. Mariam has already shown, there are many etiological reasons. So I'll just go through this slide quickly. There are genetic factors which are involved, immunological factors which are involved. And in this immunological factor, there are more than 50% immunological factors that are basically a main reason in unexplained recurrent pregnancy loss. And we will be discussing this more in our talk today, but of course, the Th1, Th2 imbalance, which is cytokine imbalance, NK cell dysregulation, T regulatory dysfunction, and autoimmunity contributes a big chunk into it. There are thrombophilic factors which are involved, anatomic factor, which include the uterine anomalies, endocrine and metabolic factor, they are there. And there is a very big piece, which is around 30 to 50%, which is still unexplained. We don't know the reason. As Dr. Mariam mentioned, that they say that something is wrong, something wrong has happened. But what is that wrong? That's the piece we need to know. That's the puzzle. That's the piece of the puzzle which is still missing. So if we look into this unexplained RPL, this is the main reason for the attraction or the interest for the role of immune dysregulation. If we somehow are able to find out the answers of this immunological factor, if you remember it from my previous slide where I was mentioning that immunological factor constitute more than 50% cases, it remains unexplained. If we are able to tell that, that will definitely help us either to reduce or to omit completely this unexplained RPL. So that's what the aim is today, that we will look into some of the tests which are available, which can help us explain why there is, what kind of immunological test can be done to answer this piece. Before we come on to the test, it's just, again, you all are an expert. We will go through this just as a revision, that the successful pregnancy requires maternal tolerance of a genetically distinct semi-allogenic fetus. When there is a normal immune tolerance, means everything is good, a successful pregnancy, there is a balanced Th1, Th2 response, there is regulated NK cells, there is adequate T regulatory functions, there is controlled inflammation, and the end result is there is successful implantation and the pregnancy maintenance. But on the other hand, if there is an immune dysregulation, there is an increased Th1 activity, there is NK cell overactivation, there is reduced T regulatory cells, and the pro-inflammatory cytokines are more into the milieu, and there is resulted into impaired implantation and pregnancy loss. So looking into it, the diagnosis of this RPL is very important, and we need to know what kind of tests which are there, which will help us to answer some part of it. So when we talk about the immunological testing, why we are going for the flow cytometry based tests, why not other tests? First and the foremost important thing, it is very rapid. Few of the flow cytometry tests, just to be on the safer side, I wrote the turnaround time is 60 minutes, but few of the flow cytometry based tests we report within 30 minutes as well. Those are not pertinent to this work, but that tells us the fastness of this technique. So it's very rapid and definitely very cost effective. It's not as expensive as the genetic tests are. So trying this, finding out the way through the flow cytometry based test is really a chance we should give. It is a very important critical bridge between unexplained RPL and mother's immunology, and it measurements of functionality. You can measure the functionality of individual cell type. So it's not something which is going to only tell you that your blood can do this. It can actually tell you your T cells are producing TNF alpha. Your B cells are producing this kind of antibody. So you can look into the individual cell type and the production or any other kind of cofactors which are involved in it. And so flow cytometry actually transform RPL evaluation from simply counting miscarriages to characterizing maternal immune environment that determines implantation, placentation, and fetal tolerance. There are 3 tests which are currently very important in this diagnosis, and they go hand in hand because they all are connected. And if you're looking into these 3 tests together, you can try to answer one piece which is missing. So the first test, which is immune subset evaluation, we call it CBC of immunology, because this is nothing. It tells you how many T cells you have, how many B cells you have, CD4 cells, CD8 cells, NK cells, NKT cells. So basically, it's the enumeration of the different cell subset type into the blood. The second test is looking into the defects in intracellular protein expression. So now you know from the first test that how many NK cells do you have, but you want to know how many of them are activated or how many of them are functional, or basically whether there is overactivation of NK cells or underactivation of NK cells. The third is functional abnormality. We perform it by assessing the cytokine released by T helper cells. Again, as I was saying before, that one of the best part of the flow cytometry is you can actually look into the one particular cell type and one particular kind of cytokine released by it. So we'll look into the T helper cells releasing different kind of cytokines, which include both Th1 and Th2. And we'll be talking about these 3 tests today in our talk. I just wanted to show this to you because I'm not sure how many of you are aware or not, but these tests are available through ONCOHELIX, and all 3 tests are part of the immunofertility panel. And as far as I know, and Dr. Khadim, please chip in if I'm saying something wrong, that this is the only program in GCC currently which is offering these tests. So, of course, this is something help to these women who are going through a lot. So we'll go through this immune profiling test, I will be focusing more on the NK cells count. This is a report which you get. As I mentioned, that this is a CBC of immunology. So you get all the different count of this. You get all this count of the different kind of cells, CD3, CD4, helper T cells, cytotoxic T cells, double negative T cell, double positive ratio, the B cells, natural killer cells, and the natural killer T cells, and you have a reference range for it. And then you have the absolute count and everything for it. But the most important thing, you get the percentages and the absolute count of this, of NK cells here. Now, when we are talking about NK cells, I'm mentioning it in the blood. So the first foremost question which I always hear, why peripheral blood? How can you correlate the peripheral NK cells with the uterine NK cells? So I agree that the peripheral NK cells are not same as the uterine NK cells. And the peripheral NK cell measurement should not be considered as a direct surrogate of the uterine NK cells number or function. I agree with that. But there are some facts, there is some scientific literature behind it, which tells us that the peripheral NK cells can be used into the diagnosis of RPL. So looking into it, the peripheral immunity, it may reflect the systemic immune activation. So women with RPL often have elevated peripheral NK number, which is activation marker, and other inflammatory cytokines, which suggests that there is a broader immune phenotype. It's not just the local uterine issue. And this peripheral NK cell measurement may identify systemic immune dysregulation and also which affects the uterine environment. The second thing is this, the peripheral NK cell function correlate better with the NK number. So there is weak or inconsistent correlation which has been seen between the peripheral NK numbers and the uterine numbers. But there is a very strong correlation available between the peripheral NK numbers and the functionality of the NK numbers and the adverse outcome. These peripheral NK cells, actually, they may represent the precursor pool of the uterine NK cells as well. So there is some evidence which tells us that this peripheral NK cells can help us into ruling out one of the part for the NK cells count. On the other hand, other can argue, why not uterine NK cells? When we are doing all this in the peripheral NK cells, why not in uterine NK cells? So of course, there are some logistics which are involved in it. So the peripheral NK cells, number one, sample collection. It's very simple. It's a simple blood draw, which can be done without any problem. But for the uterine NK cells, it's an invasive process. So doing this for as a biomarker or to rule out something, it's not that easy. The frequency of the peripheral NK cells, it can be performed at any time, multiple times if required. During implantation, during progress of the pregnancy, we can do it. But for uterine NK cells, it's very difficult and it is cycle-dependent process, and it's almost impossible to perform it multiple times. Reference ranges, there is well-established reference ranges available for peripheral NK cells for multiple different ethnicity, whereas there is no standardized reference range available for uterine NK cells. So looking into it, looks like that it's easy for us to do peripheral NK cells. So that actually answers this question, which I always hear. How do you correlate the peripheral NK cells with the uterine NK cells? Because there are many things which are involved, and there is data available which can help us correlate that. So this peripheral NK cells, it may serve as a biomarker of an underlying immune phenotype associated with implantation failure or miscarriage. This condition is exactly same when we measure the peripheral CRP, which serves as a biomarker of the inflammation, despite not measuring it from the site of disease or site of infection. So it's pretty similar. So I'll move on to my second test, which is NK cell cytotoxicity test, which is also known as CD107A production or the degranulation of NK cells. Whatever name it is, it's mainly measuring the activity of the NK cells. So what this test is, the CD107A degranulation, it is a very sensitive functional assay. It is used to measure the cytotoxicity of the NK cells. It complements the NK cell enumeration, which we did in the previous panel of the immune subset, and it helps identify hyperreactive or impaired NK cell function in RPL. So if we want to see that how do we understand about the NK cells activity by looking into NK cell degranulation. So this is a normal NK cells, and it has the cytotoxic granules, which are perforin and granzyme. It has this activating receptor, inhibitory receptor, and there is a ligand. There is a target for it. I'm not going to talk much about the activating receptor, inhibitory receptor, and the target cell because our next talk by Dr. Khan is completely focused on that. So I'll not make his talk easy like the way Dr. Mariam you did for me. Let him take his part. So I'll only deal with the part where I am involved, which is over here. So looking into it, when there is engagement of activating receptor, which overcomes the inhibitory signal, there is NK cells activation. This NK cells activation, what happens first is the perforin breaks the NK cells wall, and the Gray enzyme is released, and this enters the target cell and induces apoptosis. While this perforin is being released and the Gray enzyme is being released, at the same time, there is expression of the CD107A molecule, which are basically the marker of the NK cells activity on the NK cells. They are exposed on the NK cells. So this CD107A degranulation, it's a functional marker of NK cells activation, which is detected, the CD107A is detected by the flow cytometry. And if we look into how does it looks in the flow plots, so of course, this is unstimulated condition. You can see there is very slight CD107A production, close to 2%. But when we stimulate it under certain stimuli, you can see this, the CD107 production goes up to 17%. So this is how it looks. They look like dots, but these dots are so important into RPL and the infertility. This is how a report looks like, which we issue from the ONCOHELIX. We tell there is a reference range, which is created by us in the lab by running over 200 samples, normal healthy volunteers, females of reproductive age. And we know what is the normal range. And now we know what is the upper and the lower limit. So we can say that NK cells are underreactive or overreactive. It comes with complete percentages of NK cells being active and the interpretation part. So with this is clear that the higher number of percentage positive CD107A positive NK cells you have, the higher the NK cells activation is. So there is like a meter. If your percentage is higher, your NK cells are more active.
2 more minutes. Please, 2 more minutes.
Can I?
Okay.
Can I take 5 minutes of Dr. Mariam and Dr. Khan? Okay. I'll try to be very fast. So this NK cell degranulation measures cytotoxic potential of the NK cells rather than simply the numbers, which in turn provides whether maternal innate immunity is excessively activated or inadequately regulated during early pregnancy. Moving on, I want to make it simpler so that we can understand. So, with our first test, we can find out about the NK cells number. So there is woman A who has 12% of the NK cells, which we find out from the immune subset assay, and the woman B who has 12% of the lymphocyte. They both have the same numbers. But when we look into their CD107A expression, woman A has 5% degranulation, which falls within the normal range, whereas woman B has 30%, which shows that it's hyperactive. So this clearly tells us that based on the cytotoxic, there is a balanced cytotoxic activity which supports the implantation, placentation, and healthy pregnancy, whereas where you have hyperactive state, it means there is increased inflammation, increased trophocyte damage, and there is high risk of RPL. So for the successful pregnancy, it requires uterine NK cells to shift from cytotoxic to regulatory function. So normal function. Since I'm in the crunch of time, I will not go through that. But if there is excessive function, there is increase in the performance release, there is increase in the granzyme release, there is increase in the inflammatory cytokines, which ultimately leads to the trophoblast injury and which cause impaired or defective in implantation. And the result is, of course, we know that it's RSA, RPL, and many more things. The third test is cytokine balance, Th1, Th2 cytokine assessment, which is really a hot topic these days, whether there is a role of Th1, Th2 imbalance into the pregnancy, RSAs, RPL. So the pregnancy, which we all know, it's an immunological balance act, and a successful pregnancy requires immune tolerance, not the immune suppression. So if we look into it, there is immune protection, which is defense against infection and the maintenance of maternal health, whereas the immune tolerance is acceptance of the fetus and support of the implantation. In this process, the most important cells are CD4 positive T cells, which are also known as helper T cells. These are the master regulator, and depending on the cytokine signals, they are 4 different types. They produce 4 different types of cytokines as well. One is Th1, also known as pro-inflammatory cytokines. They have the inflammatory response by the secretion of TNF-alpha and IFN-gamma. The second one is Th2, which is also known as anti-inflammatory cytokine response, and this, which is known for immune tolerance, and they are involved into the secretion of IL-4 and IL-10. Th17 involved in inflammation and host defense secretion of IL-17. T regulatory cells, they are involved into the immune regulation. Among these, the balance between Th1 and Th2 responses are the most extensively studied and used for RPL and implantation failure. So cytokines, when we look into the correlation of the cytokines and pregnancy, in the early stages of the pregnancy, it requires mild inflammatory response, which is supported by Th1 and Th17 cells. And in this stage, IFN-gamma and TNF-alpha play a very important role. But during the maintenance period, it is mainly dominated by Th2 and regulatory T cells. And it is important for the maintenance of fetal-maternal tolerance and placental growth. And it is mainly, the key players are IL-4 and IL-10. And of course, there is plethora of literature available for the for this Th1 and Th2 cytokines being very important into pregnancy, RSAs, IVF, and we can see that there is more and more literature coming up every day, and they are talking about this. But I'm highlighting this review article. I don't know how many of you have seen it. This is from last year, July. It is basically a meta-analysis of many of the articles which are published in last many years. And this is one thing which you should read if you want to know more about this. So I will not go this because we all know Th1 response is pro-inflammatory, Th2 is anti-inflammatory. We know that there is a dedicated balance is required for a healthy pregnancy, but let's look into if there is a Th dominance, means there is excessive Th1 response, which will lead to increased inflammation, increased cytotoxic activity, and of course, the outcomes are not good. And when there is excessive Th2, which is Th2 dominance, there is oversuppression of immunity and susceptibility to infection, which is poor clearance of pathogen and possible adverse pregnancy outcome. So definitely there has to be a good balance between, I'll just move on. There should be a good balance between Th1 and Th2 so that there is a good fetal growth. And this is how the Th1, Th2 test looks like. You can see that this is no stimulus. There is no TNF, no IFN. Under normal circumstances, there should be minimal TNF and IFN gamma production. There should be minimal IL-10 and IL-4 production. But under stimulation, we can see how much TNF and IFN gamma is produced. These are the dual producers. There is IL-10 production, IL-4 production. And this actually reflects how it looks like when we are looking into a normal, healthy women and a patient with RPL, which will show a lot more of TNF and IL-10 or very less of IL-10 and IL-4. And moving on. this is how the report looks like for Th1, Th2. I'm showing this report because this is a very important piece. This report not only tells you how many are, this tells actually multiple things, but it actually focuses on TNF alpha's total number of TNF alpha positive cells out of helper T cells, IFN gamma positive T cells, and IL-4 and IL-10 T cells. It also shows you the ratio of different pro-inflammatory to anti-inflammatory cytokines. There is a normal range for it, which we have run over 300 normal healthy women of the fertile age to get this reference range. And of course, there is an interpretation which tells you that which pro or anti-inflammatory cytokine is not into the reference range. I will take 1 more minute, I promise. Okay, 2. Let's talk about the clinical utility of these tests. So there is detailed immune profiling, which provides you the number of all different immune subset, but the most important NK cells, as I showed before. There is functionality of the NK cells, which we just saw that it assesses the cytotoxic potential of the NK cells. And we talked about this in our report as well. And there is Th1, Th2 cytokine ratio, which actually tells us the potential cause of RPL, implantation failure or abortions. So the imbalance actually may help us in answering RPL or the failed IVF cycles. This is a report. This is how it looks like. And I will move on to the summary, where these tests are the tools for understanding the maternal immune environment and supporting personalized care. I'm not saying that this test will definitely tell you that there will be an implantation failure. These are the tools. We need to understand this very clearly. The successful pregnancy is never about the absence of immunity. It's about the presence of immune balance. And the third take-home message for us, the flow cytometry-based immune profiling provides a window into the maternal immune environment, which supports personalized approach to RPL, IVF, and the pregnancy care. And with that, I just want to say that these battery of tests, these 3 tests, they enables doctors with the adequate tool for the management of RPL and successful implantation and pregnancy. And thank you everybody for patient listening. Thank you, Dr. Mariam.
Thank you, Professor Poonam Dahramani. That was a very nice talk. I did not stop you because it's the very interesting subject, this immunology of NK cells. And I think every one of us in the clinic are facing patients who insisted that maybe it's the immune response, maybe it's the immune response. Anyway, thank you very much. That was very interesting. Thank you. We move on to the next talk by Professor Faisal Khan. Let me. Sorry. Maybe start again. What's wrong with this? Thank you. Professor Faisal Khan is a professor at the University of Calgary. Dr. Khan is a co-founder and CEO of ONCOHELIX Incorporation. In his clinical role, Dr. Khan works as the Director of Hematology Transitional Lab at the University of Calgary and as a Clinical Director of the Transplant Lab in Alberta Precision Labs. Dr. Khan has more than 21 years of experience in transplant immunology, cancer genomics, and histocompatibility and immunogenetics. Based on his research, Dr. Khan has published more than 105 research articles in scientific journals like Science, Blood Transplantation, and Blood Advances. Today, we will have a talk about the immunogenetics of KIR and HLA-C, the clinical applications in IVF and recurrent pregnancy loss. Professor Khan, please.
Thank you so much, Professor Salam. I appreciate this introduction. I was asked to provide, that's why I ended up writing down much. It's not much required. Ladies and gentlemen, thank you very much for attending this session. Dr. Khadan, Dr. Hani, thank you very much for organizing this wonderful event. ONCOHELIX, as Professor Salam mentioned, is an organization that stems out from University of Calgary in Canada. And at this stage, we are also existing in your backyard in Abu Dhabi as a joint venture with Burjeel Holdings. A lot of stuff that Dr. Poonam recently talked about, everything we are performing locally. As you could understand, these immune assays, they when the cells travel across the board to North America, how much reliability is there in terms of activation or inactivation is always a question mark. And that was one of the reasons why we brought this whole program here in the GCC region, so that more and more fertility program get benefit from it. And now with our collaboration and partnership with EXPRESSMED, we hope that even the reach is far bigger and broader. For today's talk, I have been asked to talk about immunogenetics. Within our ONCOHELIX family, we have the immunology folks who are more dynamic. They want to do the stuff many times to see how the immune system is evolving and how it is changing under different influences. And then there are some of us who are more genetics or molecular, who want to do one-shot test and say this is going to happen this way. So I'm the converted one. I'm the second type of person. Okay. I do have some conflict of interest because in a public healthcare system, I perform a public role, but at the same time, I also a co-founder of this private organization with multiple supports from different other different organizations. And as I'm not a pure beef burger, I'm an immunogeneticist. My experience is more about how to use immunogenetics for transplantation, for oncology, and this field is a diversion. Diversion is not the right term. It's an extension of what we were able to achieve in the field of transplantation. As I said, ONCOHELIX is an organization based out of Canada. Currently 2 functioning locations, one in Calgary, one in Abu Dhabi. And when we say 1 million samples, we're talking about 1 million very high profile next generation sequencing and high state esoteric immunology profiling type of tests that currently we are performing for several countries in Europe, Asia, and North America. Okay, let's start with what I have been asked to be here. If we look at the major milestone of the history of human genome, it starts with the laws of inheritance from Gregor Mendel, and then the theory of inheritance, genetic code, DNA structure. Ultimately, 2012, when the first draft of human genome sequence became available. This is when the twist happened. This is when how we look at medicine started changing. This draft in 2012 provided us huge amount of information. And the one which was most important was this. It says if you randomly select any 2 individuals, then genetically it is 99.9% similar. Very disheartening that only 0.1% difference between 2 individuals, that's what we're going to play with. But then if you look a little bit more in detail, this 0.1% means a difference of 3 million nucleotides, because your human genome is made up of 3 billion nucleotides. And what these 3 million nucleotides can actually do, it can give you different phenotypes. It can give you different susceptibility to diseases. It can give you different immune responses, different response of drugs, different outcome of a treatment. And these are the main 4 areas, which is what our program is mainly focusing on. How your genetic propensity guides your immune system to behave in one way or other. And if we start understanding that genetic propensity, maybe we are allowed to do some sort of modifications early in the game before the real thing happens. And that's pretty much the basis of what I'm going to be talking about today. The work that I will be showing is based on some real solid science that my team has been involved over last 2 decades. We have over 335 publications to our credit, including in journals from Science and Blood and whatnot. And all these research work are basically the basis how we have moved from translational research into the clinical diagnostics. Okay. So, Poonam has already talked about natural killer cells, why they are important, how critical their functionality is in reproductive medicine. I will be talking about why they function in one way or other. And the functioning is pretty much dictated by these natural killer cell receptors, which gives 2 types of signals, an activation signal or an inhibitory signal. And there are many. If you look it around, the top area is all made up of activating receptors. The bottom area is all made up of inhibitory receptors. And these receptors, when they interact with their ligands, they provide this signal whether NK cells should behave abnormally or normally or inhibited or activated. And the receptor which are most important among these NK cell receptors are the one which interacts with HLA class 1 ligands. They are called killer immunoglobulin-like receptors or KIRs. KIRs educate and regulate NK cells. How did they do it? So this is an overall profile of KIRs. If you look at here, KIRs have number of immunological immunoglobulin-like domains in the extracellular space, and they have different type of motif in the intracellular area. The one with the long tail have inhibitory functions. The one with the short tail have activating function. And if you look at their names, this letter L means long, which corresponds to inhibitory receptor, and this letter S corresponds to short, which means activating receptors. These intracellular segments are the one which are responsible for which type of signal transduction molecule they will be kicking in. Now, how this works? There are 14 KIR genes in human genome, and they move from generation to generation in 2 different types. The first type is called KIR genotype A, which is what this is. The red ones are inhibitory, the green ones are activating. So type A only has 1 activating gene. Type B has anywhere between 2 to 5 activating gene. Clearly, if an individual has type A, the NK cells are not performing that well. Versus if an individual has type B, it has a lot more activating genes. That's one theory. Second, as I said, these receptors need to join with their ligands to act. How that works? That works like this. This is an NK cell which is expressing its activating receptor. When the activating receptor finds its ligand, it gives the signal to cytolytic granules to come out and lyse the cells. This is how normally an activating receptor and its interaction with the ligand triggers activation. But if at the same time there is an inhibitory ligand, which is bounding to its own ligand, this engagement cancels the signature of this engagement, which leads to no lysis. This is how NK cell spares normal cells but kills abnormal cells. These abnormal cells could be tumor, could be viruses, could be anything. But what we need to know is how this receptor and ligand interaction works. If you look at overall models based on this theory, three possibilities. One, if the NK cells have too many activating receptors, then it should be more activated NK cells. Second, if there is a particular KIR gene which has more activating function, for example, 2DS1 is known to be very, very strong activating gene, then NK cells are more activated. And finally, if the inhibitory receptors don't have their ligand present, there is no inhibition happening. Clearly, NK cells are more activated. So all three models are possible. What did I do? Okay. So KIRs, activating, inhibitory, ligands, all the time, HLA class 1 molecules. These are the HLA class 1 molecules which engages with inhibitory receptors, and these are the HLA class 1 molecules which engages with the activating receptors. I'm not going to go too much into these details. Just want to focus on these two types of ligands, HLA-C2 and HLA-C1. C2 has asparagine at 80th amino acid position. It is known to have very strong bonding with KIRs, versus C1 has a weaker bonding. Okay. This is just the basic for me to start talking about what we are here to discuss, how these KIR HLA can help in reproductive medicine. Remember, take-home messages: if you are KIR haplotype A, less activation. If you're KIR haplotype B, more activated NK cells. If the ligands are C2, then stronger binding. If the ligands are C1, weaker binding. That's the only thing we need to move to the next step, which is how KIRs become so important in so many different aspects. The claim to fame continues to be transplantation. This is our own work. We have shown that NK cells are the only lymphocyte which recovers back to normal level after transplantation. And we have shown that if KIRs are not inhibited, in bone marrow transplantation, then it leads to almost threefold decrease in leukemia relapse, because more NK cell activation, less amount of leukemia relapse. This was the original work which pushed us to start looking what we could do even in the reproductive medicine, considering fetus being the semi-allograft. Okay, so what is the theory of genetic predisposition when we are talking about KIR, HLA, and fertility? First thing foremost, let's get clear. Peripheral NK cells have a mature circulatory profile, mainly CD16 positive cells. Uterine NK cells, they are CD56 positive cells present in endometrium. Peripheral NK cells, roughly 10 to 15% of your total lymphocyte. Uterine NK cells, roughly 70% of your uterine lymphocytes. So clearly the role is much more bigger in reproduction. Functionality. Peripheral NK cells, their main work is antiviral immunity, anti-tumor immunity. But uterine NK cells, they are very much responsible for how the trophoblast interacts with the uterine wall. That's where the placentation, the impact on placentation is extremely critical. Okay. Now, if the uterine NK cell, the maternal NK cell, if they have more activating interaction with the trophoblast HLA ligands, it facilitates trophoblast invasion, spiral artery remodeling, placentation, and implantation. But if the interaction is more towards inhibitory side, it leads to poor NK cell performance within the uterus, leading to failure of all these processes. Okay. Let's go back. Genotype A, poor activation. Genotype B, better activation. C2, stronger bonding. C1, weaker bonding. Okay. Then look at how the literature has evolved over last 2 decades. The first paper from University of Cambridge in UK, telling us maternal care and fetal HLA combination, because the ligands are coming from trophoblast, the KIRs are coming from uterine NK cells. Together, influences preeclampsia and reproductive success. Following a paper in 2008, same group from University of Cambridge, saying that the same interaction lead to recurrent miscarriages. Then came the Spanish group, which warmed up, one of the biggest programs, the IVI group, who are doing this work all around. The first paper in 2014 saying maternal care AA, poor activation care, guys, leads to lower live birth rate after IVF, especially if they have a strong binding C2. So strong binding C2 leading to inhibition. AA genotype leading to low activation is still making the same theory which they are trying to prove here. Multiple papers afterwards, 2018 and most recently in 2023, all of them. So here it started, if you look at here 2014, that KIR AA leads to lower live birth. The most recent one is now saying KIR B haplotype is higher live births, which is pretty similar exercise that we are doing. So genotyping maternal KIR and paternal HLA can provide us some prediction how the implantation may look like in the uterus. I'll pause. This is how the algorithm looks like. If mother has AA and father has C2, perfect recipe of NK cell inhibition. This is where there's a high risk. If mother has B and the father has C2 or fetus has C2, it is lower risk. Remember, it's the same HLA class 1 ligands who are also binding the activating genes. Just by providing more number of activating receptors here, this high risk can be converted into low risk. But if the father does not have a C2, it has C1, then this is how it looks like. Number 1 preference, number 2 preference, number 3 preference, number 4 preference. That's how it moves depending on mother's care and fetus, father's HLA profile. So if we put all of this, the whole science, the science of KIRs controlling NK cells and all the research work that have happened in last 2 decades on how this could work out, what do we see in terms of clinical utility? How it can help everyone here in your own practice, right? Very simple thing. It is not for everything. This whole algorithm is only for scenarios where you feel complexity. It's a scenario when you're using donor egg IVFs. If the repeated euploid embryo transfer failures have happened, if recurrent implantation failures have happened, if recurrent pregnancy losses have happened, there is a huge utility. But if it's a first IVF cycle, no prior failure, or if it's a male factor, tubal factor only, the utility is not there. You don't need to do this test. The utility is only and only in scenarios where you are facing the complex scenarios. Very clearly, this is where it all happens. The best utility is when you have a prior failure history or complications. And complications should be prior preeclampsia or placental insufficiency or anything. These are the segments where if you profile them, it will allow you how to select your donor correctly or how to select your embryo correctly. And this is, again, we came up with this whole algorithm. It's not very clearly defined recommendations, but this is what the best of the literature tells us. Whenever there's an evaluation, we have to look into this. 3 or more than 3 failed good quality embryo transfers, recurrent pregnancy loss, donor egg or donor sperm program, or prior severe placental diseases. If any of these things are yes, then you proceed with Kier genotyping of mother and HLA-C typing for father to know what the fetus will look like, and then interpret the risk using all the stuff that Dr. Poonam has previously talked about for NK cell, Th1, Th2, and other immune markers. But if it is no, there's no need. Just proceed without care, or it's not bringing any value to the program. So, like a scientist, as a CEO of ONCOHELIX, I would love that every IVF process should go through the Kier and HLA-C typing. But as a scientist, that's not the right thing. The right recommendation is where you are struggling. Those are the scenarios where you proceed with this type of testing. And these are the simple management strategies. This is the bad one, right? Maternal Kier AA and fetal HLA-C2C2, which is a high-risk combination, excessive inhibitory signal. What you could do, go for a C1 donor if using donor gametes. Avoid double embryo transfers when possible. Consider immune evaluation to see if there's an NK cell activation profiling going on, and then act accordingly. If it is the intermediate risk, standard IVF management, just monitor outcome. If it is the favorable one, usual IVF protocol. So it is this area, which is where the testing brings a lot of value in your practice. It is this area where, and these are the challenges. When it is going straightforward, who cares? It doesn't matter. It's this area which requires a lot more effort and support. Oops. So, in summary, again, pre-treatment counseling, testing, risk interpretation, and it is at that stage where you would like to see NK cell, Th1, Th2, immune cell subset, and other immunological biomarkers coming into play. I'll stop here and would be happy to take any questions at a later time. Thank you very much for patient listening.
Thank you, Professor Faisal, on this. The last speaker? Our last speaker now?
Maybe online.
Okay, our last speaker is Dr. Rehan Faridi. He is the Director of Molecular Diagnostics at ONCOHELIX, where he leads the efforts in precision genomics and cancer genome profiling. He holds a PhD in medical genetics and completed his postdoctoral training at the University of Calgary, Canada, certified by the American Board of Bioanalysis as a high complexity clinical laboratory director, HCLD, and the clinical consultant, CC, in molecular diagnostic. Dr. Faridi has made significant contributions to advancing molecular genetics and precision oncology in the region. Outside the molecular world, Dr. Faridi is a systems enthusiast. When he's not interpreting cancer genomes, he is building automated system to make laboratories run smarter. Please, Professor Faridi. Hello.
Yes, hi, just thank you so much for this introduction. And just wanted to confirm
Please.
if you can see my screen and hear me as well. Okay, I'm assuming that you can see my screen.
Yes, doctor, you can see your screen.
Yes. All right. Thank you. Thank you very much for indulging me. I mean, I'm here in British Columbia valleys and not there in person, but having my moshi moment here. Taking it from like a notch below what Dr. Khan has so elegantly explained, as well as what Dr. Poonam had laid the foundations to. What I'm going to tell you is a bit more simpler than that, and it is much later into the journey of human reproduction. What we also kind of serve as far as our testing menu is concerned is a non-invasive prenatal testing, and this is for early screening of pregnancies for any genetic abnormalities that the fetus may have. So in this talk, I will briefly explain, the principle, the practice, and the interpretations that go into this particular testing. Okay. These are my disclosures. I have no financial disclosure or conflict of interest. I will try to keep it short, but we'll try to build a foundation of cell-free DNA biology on which the non-invasive prenatal testing is done. What are the chromosomal targets and then screening methodologies? A very brief about introduction of about our program. What do we do with respect to how this fits into the guidelines and related to the care of pregnant women. Some differentiators of what we do and how differently we do it. I have two specific differentiator to highlight, and then I'll try to do that in this talk. Some interesting cases to drive the message home and summarize it short after. So the reason why NIPT is happening in the first place. Now, 10 to 15% of clinically recognized pregnancies are lost, and roughly half of them are driven by fetal chromosomal abnormalities. 1 in 25 babies are born with any, structural chromosomal abnormalities, and this burden is a bit higher in the GCC because of consanguinity and some foundation effects that basically amplify the baseline risk in this region. More or less, most of the chromosomal abnormalities, they remain silent, they're undetected until they present as a loss or anomaly or a neonatal disease. And so this, our ability to accurately screen early in the pregnancy can at least, shift the clinical conversation from reactive to anticipatory care. What is NIPT looking for? NIPT specifically is looking for aneuploidies where whole chromosomes are either lost or there is an increase in it. Structural anomalies including microdeletions, duplications, translocations, and balanced and unbalanced translocations in some cases, and mosaicism where there are more than one genotype in the fetus or placenta. So the common autosomal aneuploidies, which we all know and we are quite familiar with, is one of the most common is Down syndrome, which is a result of trisomy 21. Down syndrome is fairly high in incidence. It is associated with intellectual disability and then characteristic facial congenital heart diseases in roughly 50% of the cases. But the life expectancy is good, is about 60% with the care that we have today. Adverse syndrome, on the other hand, is relatively less frequent as compared to Down syndrome, associated with severe intellectual disability, intrauterine growth restriction, and the mortality is very poor. 90% of the babies die within the first year with trisomy 18. Trisomy 13 is the Patau syndrome, also associated with severe cardiac defects, cleft lip, characteristic palate, and most babies born with the Patau syndrome or the trisomy 13 do not survive past the first weeks of life. So it's pretty daunting to have one of these conditions, and then to know them early in pregnancy is opens a window of opportunity that something can be done about it. Now, beyond these big three, there are monosomies, X chromosome monoclomies, or sex chromosome aneuploidies, including Turner syndrome, XXX, Klinefelter, or Jacob syndrome. And then there are many subchromosomal macrodeletions, but these are the 5 that are most clinically relevant: the DiGeorge syndrome, Prader-Willi, Triducat, etc. These are the ones that NIPT screen looks for. So what are we looking at here? So if you look on the left side of the picture, where there is a placenta and then basically made up of trophoblast cells. During the course of pregnancy, the cells shed, the cells die, and they shed their cell-free DNA into the maternal blood. So both maternal cells as well as the trophoblasts, which are a surrogate for fetal origin cells, they shed their cell-free DNA into the maternal blood, and it is that DNA that can be non-invasively, with a simple blood draw, can be obtained and extracted. Now, cell-free DNA fragments, they circulate in maternal plasma, and the fetal component is derived from placenta. Now, the fraction of the cell-free DNA that is in placental in origin, which is relatively shorter in size as compared to the one that is derived from the maternal cells, is called fetal fraction. And we'll talk a little bit more about it so in the subsequent slides. Fetal cell-free DNA gets cleared within hours of delivery, which means that the signature that you're seeing in maternal plasma in any given pregnancy is specific to that pregnancy alone. Does not carry forward into the next one, or does not have remnants from the previous one. Now, because cell-free DNA is placental, so the results can reflect the placental status rather than directly with fetus, but it still provides important insights into what's going on there. Most commonly, non-invasive prenatal testing is done using whole genome sequencing. So there are some targeted SNP-based assays where both mother and father are tested, and in their reference, the fetus is tested. And then there are other, targeted capture methods, and most pipelines are black box, and most pipelines are we don't have access to it, but we do things a bit differently here. So in ONCOHELIX, both in Canada as well as in Abu Dhabi, the NIPT test is offered at 2 levels. One is Serenity, and the other is called Serenity Plus. Basically, the depth of information that is, or the width of information that is available in each of those tests differs. And the 5 chromosome is the first line screening, where we test for the big 3, which is trisomy 21, trisomy 18, and trisomy 13. In addition to that, chromosomes X and Y, so fetal gender identification, as well as in some cases sex chromosome aneuploidies as well, because we are looking at them. The other one is the full picture, where all 24 chromosomes, including the big 3 and rare autosomal trisomies, as well as microdeletions, are analyzed and reported in the broader panel. So for CRO, trisomies plus sex, we'll call it's Serenity, and then you can upgrade it to have it for the full picture in the Serenity Plus. I talked about our 2 differentiators. One is this one. So the analysis that we do is our own in-house bioinformatics engine, which basically gives us control as well as information on what is going on as far as this analysis is concerned. Now, this is the pipeline that we developed and validated in-house and has great performance characteristics. More importantly, it is agnostic to the sequencing methodology and platform, so it doesn't matter where the data is coming from. We can analyze it, and then the baseline against which the aneuploidies are being analyzed are adaptive baselines from in-house sequencing, which is also population specific. So when it comes to actual testing, there are steps, and again, in every in the fertility clinic, this is probably pretty common that a pre-test counseling is offered to the patients. So one of the most important things to know is that it is a screen. It's not a diagnostic. A positive result requires a diagnostic confirmation. So that's one thing to know. What are we testing? Like I said, the conditions within the panel, which is T21, 18, 13, sex chromosome aneuploidies, plus select microdeletions and their expected performance. It is not a comprehensive genetic screen. It will not detect single gene disorders. It will not detect most SNVs or structural defects and non-translated deletions. They're not covered. Possible results, you can have all three types of possible results. Even a no call is a result. So when we are not able to reliably ascertain whether there is a positive result or a negative result, that also has some implications, and that we can talk about. There are possibilities of incidental findings, and we've had cases where we even detected a very early malignancy in one of the patient, and it was at the time seemed very unfortunate, but the physicians were able to quickly act on it, and it was actually quite beneficial to her management. So it's optional. They can decline if they do not want to have that test. This snapshot is how a report looks like, and this is a report from 5 chromosome analysis. Some of the things to look for in the report beyond the demographics is the gestational age. So the test is performed as early as 10 weeks of gestation. What type of sample was tested, and what is the fetal fraction? The fetal fraction is one of the key metrics, and the results and positive predictive value and other findings. It is also important in case of high-risk results to have the genetic counseling available to the patient so that the patient gets to know what these results actually mean. It's not a simple positive or no, positive or negative result. It's not a diagnostic test and stuff like that. As far as the American guidelines are concerned, it is becoming more and more common to offer an IPT in practice. As a matter of fact, it should be offered to all pregnant women. And then the screening is something that should be offered, and one approach at a time. So not multiple screenings. A negative results reduces but does not eliminate the chances of the target or the risk of aneuploidies. So that's important to know. In cases of twin pregnancies, the data is relatively limited, but at least for the big three, which is T21, 13, and 18, there is some data that can support the findings. If there is a positive screen, they need to be confirmed. And second trimester ultrasound is fairly standard, so it is offered at 18 to 22 weeks of gestation. But the advantage of an IPT is that it is offered early in pregnancy, like as early as 10 weeks of gestation, and subsequent ultrasound can confirm or confirm the diagnosis if it is there. In the regional context, we alluded to this earlier, that there is a higher baseline of genetic risk because of founder effects, because of consanguinity. In some cases, advanced maternal age, and also there is growing access to care. So more testing leads to more detection. So aneuploidy screen and carrier screenings are complementary, although both are done. And the population-specific reference baselines that we use in our in-house testing gives us the real picture of any aneuploidy. This is our second differentiator. And that what we try to explain that how the results are interpreted in our testing. Now, the single most important sample level quality metrics is the fetal fraction, like how much of the fetal cell-free DNA we found in the maternal plasma, how much was it available for testing. Now, fetal fraction is the ratio of the cell-free DNA coming from the fetus versus the one that is coming from the maternal cells. Now, there are certain factors that can lower fetal fraction. Some of them are quite well known. High maternal BMI can, logically, it has a dilutional effect on from maternal cfDNA, because in case of high maternal BMI, there's more maternal cell-free DNA in the plasma as compared to the cell-free DNA. So that leads to low fraction of fetal DNA. Early gestational age, fetal fraction tends to increase as the gestational age progresses. So if we do not detect enough fetal DNA at, let's say, 10 or 11 weeks of gestation, we recommend to come back at 2 to 3 weeks after, down the road, and then we expect to get a higher fetal fraction. But at the same time, if the fetal fraction continues to stay, low, even after 14 weeks of gestation, that itself could be an indication of certain fetal aneuploidies. For example, in case of Patau syndrome and Edwards syndrome, these are associated with lower placental mass, and that can also lead to low fetal fraction. So this basically means that even if there are no results, then they should be looked at with caution. The 4 key numbers that distinguish, that explain what a positive or a negative result could mean. This is the sensitivity, specificity, fairly standard, where your ratio of true positives versus total means sensitivity. What that means is that of all the truly affected pregnancies, how many of them we can faithfully detect as positive. At the same time, specificity means of all the truly unaffected or the normal pregnancies, what are correctly negative. So that in our hands, it is 99.9%, for example. The other 2 values are derived from the sensitivity and the specificity, but they also take into account the prevalence. The positive predictive value and the negative predictive value. What that means is that in case of positive predictive value, if a test is positive, then what is the probability of the fetus actually being abnormal in terms of the genetics? And that takes into account the maternal age and what is the prevalence of the condition that we're talking about. Same for negative predictive value. If the test is negative, what are the odds of the fetus being normal, in case of negative results? So the prevalence is important here, and why we emphasize the prevalence is because after, as a physician, if you have received a result that tells you that there is a high risk of a chromosome 21 trisomy, there's a high risk of Down syndrome, what are you going to tell to your patients? What are the next steps? That is fairly standard in clinical practice, and we tend to highlight it in our reports as well as in our conversations. So just taking an example here, let's say we screen 10,000 low risk patients, which means if we were to screen 25-year-old pregnant women, 10,000 in number. So based on its prevalence, the truly affected cases would be randomly about 7 of 10,000 would be affected. Now, in this case, if our sensitivity is 99%, we can detect 7, all 7 of them, right? And the remaining, the unaffected ones, are 9,993. And with our specificity, and you cannot have greater specificity than 99.9%, we would still be flagging almost 10 which are negative, that would be flagged as positive because we tested a high number of patients. So the total positive results is 7 true and 10 false. That makes it 17, and the positive predictive value is 41%. What that means is that if you have a 25-year-old woman that you have tested and that has tested positive for T21, there's a only 40% chance of that person being truly positive. So 6 out of those 10 cases will be a false flag. So that doesn't mean that it is not a specific test. What that means is that the idea here is that it's a theory of variable statistics, because you came from a very high risk situation, very rare situation, that 1 in 1350 down to 1 in 4 or 1 in 6, that type of thing. So the rare events are harder to predict because for rare events we do not have prevalence, but for the more common ones we have the prevalence data available. So how does it work? The positive predictive value takes into account sensitivity as well as prevalence, and then also the specificity. So prevalence is the pretest probability. So if you do not test at all and you randomly sample the population, the population, you'll see that 1 in 1400 will be positive for T21 if they are 25-year-olds. Sensitivity is the lab performance, and specificity is also performance from the platform. So how does likelihood ratio factor in? So the likelihood of a positive result to be truly positive is called the likelihood ratio. So you pick the prior, which means the prevalence. So if, let's say, for a 30-year-old pregnant lady, the risk of trisomy 21 is 1 in 900, which means out of 900 pregnancies, 1 will be positive, 899 will be negative. And if you apply the likelihood ratio with the platform, which is 99% sensitivity and 99.9% specificity, what you'll see is that likelihood ratio is 0.99 over 0.001, which is 990. And when you multiply this, the likelihood ratio to your t-test risk turns out to be 1.1, which means the positive predictive value in this case is 51%. That reduces or increases the risk of trisomy 21 from being 1 in 900 to a flip of a coin. And that variable change in statistics is something that is to look for and also explain to the patient that this is not the end of the road. There is still 50% of the chance that this could be a false flag, because at your age, it is not very common to have trisomy 21, even if the screening results are positive. So the positive predictive value changes dramatically in some cases by maternal age. So if you look at this table, the maternal age is from 20 to 40. And what I've done here is I've done prior T21 risk and compared it with prior risk for trisomy 18 and trisomy 13. Just by the look at it, you will see that the positive predictive value of trisomy 21 increases dramatically by age. So at 25 versus at 40, the PPV can increase. But for rarer conditions, the positive predictive value doesn't increase that dramatically. If you have a 40-year-old pregnant woman who has given you a positive result for trisomy 18, the positive predictive value is only 16, which means there is 1 in 8 chances that this might still be a false flag. So just towards the end of it, I have some cases to drive the points home. This is the case 1 in which a 25-year-old singleton pregnancy was first screened, so there's no relevant obstetric or family history, and IPT was ordered as a primary screen, and the result is positive. Now, fetal fraction is 11%, lab estimated positive predictive value at 40%, like we assessed before. So 60% of the chance that the fetus is still unaffected because the PPV is 40%. The patient is pretty young, the prevalence is low, so there's an inherent low risk of T21 just by random sampling. So we would refer this patient for genetic counseling and 13, 12, do an ultrasound earlier instead of waiting for a second trimester. So 12 to 13 week ultrasound and offer diagnostics. So the available options are CVS or amniocentesis, just for the confirmation. So the result, essentially the bottom line is the result flags a higher chance of Down syndrome, but at this age, about 6 of 10 positive screens are false alarms. So let's confirm. This is another case from a 40-year-old abnormal ultrasound. So the ultrasound has already shown some sort of anomaly. We do the NIPT screen in the presence of intrauterine growth restriction that we know is associated with the trisomy 18. Fetal fraction is 5%, lab PPV is 16%. Now, even at this low positive predictive value, with an intrauterine growth restriction being seen at ultrasound, this is probably the point in the same direction. The screen and the ultrasound both point in the same direction, but you would still want a definitive answer before you make any decision. And then confirmation is essentially the next step. Mosaicism is a reality. So in some cases, the mosaicism are sporadic; they get ruled out. But in some cases, they can be persistent. So we found a case in which we reported. So there was a low signal of chromosome X, which could point to Turner syndrome, but this doesn't happen in males. And there was a Y chromosome signal as well. So if you see the bottom plot, this last bar is chromosome Y, and this the one before it is chromosome X towards the very end of the picture here. So what this means is that this result is consistent with some cells having a X chromosome loss versus some cells. And that X chromosome loss brings the overall signal of chromosome X below. But since the patient is male, so that's not a Turner syndrome. So we report it out as there is a mosaicism. And then the patient comes back to us at about another. So this patient was tested at 24 weeks, which means was pretty late in pregnancy already. Would have been in the window where the ultrasound is happening. And but in any case, we reported it out because if we wanted to do a repeat, then it would have been further delayed in the pregnancy. But nevertheless, they came back for a repeat test, and next time it was an even stronger presentation of the same effect. Most likely explanation is that with advanced age, this is not that advanced of an age anyway, but with age, some X chromosomes tend to get lost, and then the fetal monosomy X confined placental mosaicism becomes a fairly common occurrence. This is the result from the second screen. So what does the positive result mean? As a step one, do not, so the bottom line is there's no irreversible decision that ever needs to be based on an NIPT result alone. So if you see a positive result, the step one is counsel and do a comprehensive ultrasound. That's always the case. If the ultrasound is concordance, that basically confirms the risk being pointed in the same direction as we saw the case number 2, then it still requires further confirmation through CVS or amniocentesis, depending on the patient preference as well as where in pregnancy this particular patient is. If the ultrasound is normal, then the diagnostic testing may still be required because you want to look at things more closely, but the same pathway. If there is a low or a prior or an unusual result, for example, the patient is young, there's no features, there is a rare autosomal trisomy. We recently had a case where we detected a monosomy of chromosome 5, which means from the signal, it would mean that the chromosome 5 is lost. But the gestational age is 14 weeks. So there's no way a fetus will survive 14 weeks with the loss of chromosome 5. So those decisions are important to come out in the report as well as in the genetic counseling. So we discarded it, mentioned it, and then reduced the weightage of it, that this is nothing to be worried about, because if chromosome 5 is lost, then the fetus doesn't survive beyond a couple of weeks. So if there is no feature, there's biological inconsistency, still the positive result must be recorded, but with the appropriate context is the bottom line here. So like the case I just mentioned, when does an IPT disagrees with the truth? In cases of confined placental mosaicism, it's a known phenomenon. Placenta carries the aneuploidy, but the fetus does not. So you are seeing the signal that is coming from the placenta, but not from the actual fetus, because it's still a surrogate testing. In some cases, there is true fetal mosaicism. There are two cell lines in the fetus. Sampling and timing can influence the decision. If you repeat the test, perhaps the fetal mosaicism still gets reproduced. Vanishing twins scenario is also fairly common in many twin pregnancies. They start out as a twin pregnancy, but one of the fetus dies in the process, and but the aneuploidy signal that you're seeing is coming from the fetus that is no longer there, and the remaining fetus is healthy. Maternal series of mosaicisms, maternal malignancies are also something that we have seen it for ourselves. Gives you a lot of signals across all the different chromosomes, and that is a hallmark of maternal malignancies, because there is a lot of DNA damage that is going on in certain cells. And a low fetal fraction is also very common. If you do not have enough fetal cells to begin with, and the results can be, you cannot be sure about the results. So borderline fetal fraction gives us sometimes discordant results. We already talked about this in the flow chart, but basically it sums up that post-test counseling is critical.
1 minute.
Be it a positive, just finishing. So be it a positive or a negative or a no-call result. A special mention to twins. If the dichorionic twins are there, then the fetal fraction is a split between the two fetus. So a 4% fetal fraction would mean that 2% coming from each one of them, which is still low. So the performance and data is limited in case of dichorionic twins. Monochorionic twins, on the other hand, they have the same genetic makeup, so the concordance is assumed for aneuploidy. So if you are seeing an aneuploidy in a monochorionic twins, that means both the fetus are affected with that, or at least there is a high risk in that case, and the confirmation is required. The cases of vanishing twins, I already mentioned. In case of IVF, there's a very important nuance here, that in case of IVF or egg donation, the age of the donor must be taken into account rather than the pregnant lady herself, because it is the age of the egg donor that is the bottom line for risk. In case if there is any previous aneuploidy, the post-test probability increases. The PPV also accordingly increases. In case of maternal transplant, again, the donor-derived cell-free DNA may interfere with fetal signals, so this has to be taken into account as a pre-test coordination. Confirmatory diagnostic testing, there are two options, CVS and amniocentesis. Everything else is the same. The importance here is the mosaicism risk. If you want to rule out mosaicism, the mosaicism risk is still higher because you are sampling the CVS, which is fetal in origin, which is placental in origin, versus amniocentesis is a true fetal sample. So in case of mosaic results, amniocentesis is the gold standard to rule out any positive or negative result that we are seeing. But depending on, the choice is driven primarily by the gestational age. It is more common to do amniocentesis beyond 15 weeks of gestation, but CVS can be done, before and after both. And patient preference, because both of these are invasive forms of testing. Final slide to mention the key takeaways. NIPT is a screen, not a diagnosis. We cannot say this enough times that the positive results always requires a diagnostic information. Fetal fraction is the single most important QC metric. Results at or below the threshold are less reliable. Borderline signals at low fetal fractions, usually we repeat those tests. Positive predictive value. Again, this is one of the very important metric. It depends on the prior risk. It depends on the maternal age, and it truly tells you what your next step should be after receiving a positive result. Sex chromosome aneuploidies have inherently low positive predictive values, and these are the most common results that show up because of confined placental mosaicism, because it is the X and Y chromosome. X chromosome loss is quite common in these cases. And just like any other positive result, confirmatory testing is essential here. We do not take into account all of these metrics just to reflect that, we know that there is a sex chromosome aneuploidy, that it could be negative, but we are showing it as positive, and we better preserve our own statistics. What we do is we report these validated signals conservatively. We report them rather than suppressing them, and it is very important to open that door of the dialogue with the clinicians as on methodology as required. A no call is also a valid clinical finding. If on repeated tests we're not seeing results, that means the clinical counseling and further diagnostics is required. And the Bayesian habit, the knowing the positive predictive values, the likelihood ratios, and communicating them with the results with both physicians and patients in the probabilistic terms and patient-specific terms is the key here. With this, I thank you all for indulging me from across the planet. These are some of the many people that I have to acknowledge, and I'm happy to take any questions if there are. Thank you.
Thank you, Dr. Faridi. We can open the floor for questions. Yes, Dr. please.
So since we are in private, the repetition of the test, how we will counsel the patient, and the repetition of the test will be on the expense of patients, right? Or it is complementary from the lab. I don't know regarding this things.
So
if the fetal fraction is less than 4.
Yeah, so we offer the test at no cost to the patient if a repeat test is required. Majority of the time, that is the case. Yeah.
Yeah, because the report is issued with the so no. What I mean, if we receive the report with the finding, and the patient came for counseling, since the repetition is recommended, so I mean, no need to submit the report if repetition of the test is recommended, because the accuracy will be less, right?
Yeah, I mean, if the fetal fraction is low and there is no result for this particular, specifically talking about the fetal fractions, if as a result of low fetal fraction, let's say we detected 2.4 or 1.9, so we will release the result for this particular collection, because the next result would be for a subsequent collection for a different gestational age. So there are two components to it. You're repeating the test at another time point down the road in the pregnancy. And that is what will be reflected in the report that comes afterwards. Now, in the second test, there are further two possibilities. Let's say further at 14 or 15 weeks of gestation, the fetal fraction still remains low. There is no point of further repeated testing, because at this stage, we have to look at the reason why the fetal fraction consistently stays low. So that's one aspect from the testing point of view, and the other aspect from the cost point of view as a policy, if we have to repeat the test, it is done. The cost of that test does not passed on to the patient.
Thank you.
Yeah.
Any other question?
In case of twins, vanishing twin, how accurate is it? And when to repeat the test if we have a vanishing twin?
So it is so we require that information from the ordering provider, because that history is important to know for us to appropriately interpret the results. So what happens is, in case of one vanishing twin, you cannot for sure say that the signal, a positive signal, is coming from the living fetus, or is it a remnant of the fetus who has perhaps died because of that abnormality that we are seeing. So this is where the screening information, this is as far as the screening information can take you. And if the context is of a vanishing twin, then the best option or the confirmatory option is CVS or amniocentesis further down the line. So that's what we require at the ordering, at the point of order, that the physician must inform that this is a case of a vanishing twin. And the results are limited to the ones that for which the prevalence is known, which is the 3 chromosomes, T21, 18, and 13, and XY.
Any other question, please? One second.
I have one comment. Thank you for everything. I enjoy your lecture. But for my surrounding, I noticed they use an IB test as a gender reveal. It's like they don't know exactly where there is 2 packages, full try and only try 21. So they choose only try 21, so only to know the gender. Usually in our culture, so they are not using it as it is.
Yeah, I mean that's very true, and as providers of the test, and I guess Dr. Khan can add more weightage to what I'm saying here, is that as providers of the test, your intentions are to know the abnormality, to be able to detect the screen, by a screening test, to be able to detect the abnormal, because sex chromosome aneuploidies are a reality, so you wouldn't know unless you screen for them. It's also a reality that test is and can be used for other purposes. And I would let I guess Dr. Khan has more clarity on that from his point of view.
I think that's the irony. We have 2 versions, the 5 chromosome and the complete one. And we consistently see, for example, in Canada, gender is revealed on the ultrasound itself. There is no barrier to gender revelation. And we always see it's the Serenity Plus request versus in the region here. We have seen when the requests are coming from hospitals and the Obs-Gynae program in proper hospitals, it's all the time it's Serenity Plus. They want complete information. When requests are more coming from medical centers, that's when we see there's a huge increase of only 5 chromosome information. But at least at the laboratory perspective, it is so difficult for us to differentiate who really want to know the gender or who want to know the abnormality. What we have done as at least an ethical attempt, we have kept the price gap between the 2 tests minimal. If I will be the person want to know any abnormality for my kid, I would absolutely go for a complete package rather than going for a 5 chromosome, especially if the price gap is minimal. That's the least we could do to avoid the situation, and that's what we are trying to do here.
Yeah, And there is one other flip side to it as well, at least from the Canadian perspective. Once our conversations with the providers over there is that sometimes too much information. I mean, they have a different narrative to say. Sometimes too much information, puts a unnecessary burden on the public healthcare system. It creates a lot of anxieties. For example, in this case, we sat on the report for 2 weeks, 2 days, that it's a valid chromosome monosomy 5 signals, and we can tell you for sure that this is a technical artifact, because there's no way the fetus is surviving 14 weeks in this case. But as soon as the patient receives the results, the anxiety, folks are pregnant, are anxious in this journey anyway, and these type of results just increase their anxiety. So knowing and physicians at this interface, we believe are the most critical space to translate the results in the Bayesian terms and probabilistic terms is what our message is, I guess.
Just to make it short, not to emphasize more, just regarding the comment, since we are doing a lot of NIPT for patients who did not go for BGTA, and yet even for patients who are going for BGTA, still sometimes we are doing the NIPT as a dual check for those patients. Yes, since you have the technology, why don't you use the technology? If you can't afford the technology, why don't you use the technology? We should not make it as a stigma if the couple would like to know the gender of their baby. Yet, because maybe we are dealing with more infertility patients compared to the people who are dealing with a spontaneous pregnancy. So OB/GYN clinic compared to an IVF clinic is completely different. IVF patients, they are keen to get pregnant, and they are so worried about the health or well-being of their babies, as a normal couple, of course, but they got it with a lot of struggle. They want to get everything sure that everything is okay. So yes, they are welcoming. We have a lot of patients now. They are coming. We are recommending that, especially when we are doing the NT scan. We are combining them together, the NT scan as well as the NIPT. And sometimes ultrasound will not show early. It may take a little bit more time. So let them enjoy if they want to know the gender. We are different than the other places where you are worried about that they will terminate the pregnancy because they are worried about we know in certain societies, they are more keen to have a specific gender, and they may harm this pregnancy and go for termination if they will know what is the gender earlier. And this is not allowed in our society. So we know that there is no harm by any means. So let them enjoy the moment if they want to enjoy it. Why not? My question is something different. I guess as a physicians, as a clinician, as well as the patients, one of the important things is not only the efficacy, but the cost is very important. I don't know whether in Canada, we know that in a lot of places, the cost is covered by the insurance, yet unfortunately, we don't have an insurance coverage. Yes, we do have a governmental hospital where they cannot afford all those expenses or those tests, but the insurance does not cover even IVF. And in most of the setup, it's mostly done in a private sector. So what about the cost if we will look on this perspective? And on the other side, sometimes you will say, okay, I did all those tests. Some of them will come positive. Some of them will come negative. What next? So those questions also, yes, is important, because as we figure out an issue, we can figure out the solution. But sometimes, again, you will go on the first square where you cannot do much. If anyone would like to.
Can I elaborate on that? That in Bahrain, we are talking about IVF pregnancies. That law states that you cannot do sex. You don't do sex selection. Therefore, you do not do sex chromosome screening before implantation. Once the pregnancy has been established, then I don't think anybody would like to terminate because it's a boy or a girl. Okay, they know it's a boy, good. Some families would like to have a girl rather than a boy, but as Dr. Haifa said, that this Bahrain is not like other countries that we insist on certain sex because of social stigma or social conditions. In Bahrain, in Kuwait, in all the Arabic countries, they welcome the pregnancy, especially the IVF trial for conception, whatever sex is. So before is not allowed, but after pregnancy, I don't think there is any reason not to tell the patient what sex of the baby is.
In Canada, patients are actually upset if you tell them gender ahead of the time because they really want to keep it secret and they want to be as a surprise to them. So, in my own case, they told me the gender when they were doing my ultrasound, and I was like, "Why did you told me? I really wanted to have a surprise at the end." But again, like every society is different, but I kind of agree that, knowing it is a lot of pleasure. You can buy the same color clothes for the kid. You can enjoy. Yes.
We often ask the patient for the ultrasound. Are you keen? You want to know what is the gender of the baby.
Yeah.
Still we have those young generation who want either too much gender reveal parties or they want gender parties. Everybody. So you have to deal with different types.
Especially Thursday, we are very pressurized to give the result on Thursday night, so that on Friday, it's really in Bahrain. Many patients, they are watching on this turnaround time and they are asking, you have to give the result on Thursday so that I can save my money. I think in Bahrain, you people are doing gender reveal part. So no problem, we have given on Thursday, why not let them enjoy?
And Dr. Haifa, to answer your first question about who will cover, whether it's Canada or UAE or Bahrain, IVF is not covered by any insurance. A lot of tests they do. For me, these specialized immunology tests, they are not to ensure pregnancy is successful in the first go. These are only when you're seeing repeated failures. We need to know why they are failing. There's no point to put more money in another process unless you determine what's there. This is how we continue to promote that. Just don't go all out for these tests. These are very specialized tests, but have a huge value for people who have repeated failures. And that's what we recommend. In Canada, although the Th1, Th2 cytokine ratio, they're recommending for every IVF process, mainly because of different forms of autoimmunity still continuing to be the case. But NK cells and KIRs are mainly when you have multiple failed attempts that you want to.
Okay.
In Canada, it's not. In Abu Dhabi, it's partially covered.
Okay. We conclude this with great thanks to all who have contributed to this scientific gathering, starting with Professor Haifa, Dr. Mariam, Dr. Dahramani, Professor Faisal, and all those who have attended. Thank you very much for this gathering. Now it's time to give some memorandum thing to be remembered. First, we will start with Dr. Mariam.
So,
Please. Yeah, most. Next.
دقيقة.
شكرا. Next, Dr. Dahramani. Thank you.
Absolutely.
دكتورة مريم بعد تصاميم
ترجعي.
الدكتور سامش حامل ماء.
Is Professor Faisal. Next.
Thank you very much.
You're most welcome. Pleasure. And this is for Dr. Faridi. Please, Dr. Amir. This is on behalf of Dr. Faridi. Thank you.
Thank you very much.
And this is to Professor Haifa, please. أهلا وسهلا دائما أهلا وسهلا. شكرا.
And definitely Dr. Salam Jibreel. Dr. Kadam, please.
Thank you very much. Thank you. شكرا 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 جزيلا للجميع. Thank you all. Thank you all. دكتور
دكتور مريم صوري ما صورت مع دكتور.
Can we have a group photo?
And please, if you can join us for the group photo.
تعالوا هالصوب أحسن. حفصة تعالوا. ما راح تفضلين. أي ما راح فيا. تعالي هيدي شوي حفصة. عشان توصل. على حسب